Now, our STRATICYTE test is based on a protein biomarker that's been extensively studied, and it has been shown to help cancer cells invade and migrate and metastasize. And so it stands to reason that before a precancerous lesion becomes malignant, that it will overexpress this protein. Now, here you can tell on the left, this is a normal H&E slide viewed by the pathologist, but here we see abundant overexpression of S100. This platform does a tremendous job uh, because it was based on 811 biomarkers, and S100A7 outperformed all of them. So looking at a huge number of biomarkers and picking the best performing one was a great strategy to develop this test. And so here's an example of how it works in real time. There's a special stain applied, and then a scanner looks at all of the epithelium. Normally, a pathologist looks with the microscope and scans all the epithelium, and then looks at the area where it looks the most concerning. This is all digitized, and so the volume of each individual cell is measured, and then a region of interest is identified with the greatest expression and the greatest abnormality in cell size. And based on a database of 150 cases with known clinical outcomes, all patients who had precancer, some of whom developed into cancer, this test can compare these findings with those patients, and that's actually where the patent is. That's where the secret is, which is being able to predict based on these findings which patients will develop cancer. So you, as the clinician, get a score back. You get your 5-year risk of probability, 5-year probability of progression to cancer, and you get to now tell your patient your risk is X, not I don't really know the range. It's anywhere from 1 to 40%. We're not sure what to do. You get to confidently look at that patient and say, we have a risk, and now we're going to decide for behavior modification, increased follow-ups, laser treatment, excision, or whatever it may be. What I've seen in this is it's actually a practice builder. Patients come expecting this kind of conversation, and very educated people I have found seek us out because they want this dynamic. Our chair emeritus of the Department of Surgery, excellent surgeon, not always a huge supporter of OMS in his time here, but he brought his wife specifically for this test for me to offer. So we see increasing credibility, and it really helps, I think, to reestablish that trust between the patient and doctor, when in the past we've always had that bit of ambiguity and that uncertainty in managing dysplasia. So lots of data that we can make available to John after the call. We've got, any of you who are interested in the papers and all the data behind this, but suffice to say, all of these are changes happening at the pre-microscopic level. So even if the pathologist sees dysplasia, we're not really looking at that with the STRATICYTE test. We're looking at the molecular changes behind the scenes that can't be detected. And so this is kind of the standard we're all used to, the way we were all trained. We have a patient who has a suspicious lesion seen by the dentist. They're sent to us for a biopsy. We send that to histopath, and we get results back with ambiguity. But now the same exact process is followed. We don't have any new biopsy that's required. Your exact same procedure can be performed, and that tissue is sent to your pathologist, and then that same tissue can also be sent to for STRATICYTE testing. And Dr. Paris Patel, who's next, will talk a little bit more about the specifics of that as the lab director in Dallas. So now you get this report back. You've still done everything the same for the patient, still received that referral from the dentist, you've still done the biopsy, but now you get histopath. You'll still get your same biopsy report you always have, but now you get this additional piece of information that really in my practice has been revolutionary. I mean, it's really changed the conversation and the management for patients. It also has informed follow-up. When patients in the past were told they had mild or moderate dysplasia, they didn't always come back. We'd lose them to follow-up. Life gets in the way, and they wouldn't come back and see us. Now they'll come back and say, well, I know I have a 30% risk, and I need to be followed. And so it really helps with patient compliance too.
This is the next step. This is the era that we need to be living in. This is the era that we really need to be pushing for in regard to what else can we give our patients? What else can we give ourselves to help us better manage these patients, right? So pretty basic algorithm. I'm not going to reiterate this, but there's really nothing on the clinician side as far as any additional biopsy or anything like that. This is very simple. most of you should be aware that tissue block remains in a pathology practice for years. If it's an academic institution, typically it's decades and decades because that's research material, right? All you have to do, even for retrospective cases, if you want, go back and say, hey, you know what? We're going to order this test on this patient that I saw 2 years ago, 5 years ago, 7 years ago. It is more likely than not that the lab has that tissue and it can be sent off for this protein overexpression because everything is fixed and formalin embedded and paraffin embedded. So this is something that can be utilized not just prospectively, but also retrospectively for a lot of patients that we see in our practice.